All right. So last time when we were recording wrist, we got cut off on those last couple of slides. So before we go into forearm, I would like to go back and just make sure that we cover two of the specialty views of the wrist that were cut off in that last one. We did discuss the ulnar deviation and we discussed the modified Stetcher method. Those are both on 154 and 155 in your textbook of radiographic positioning and related anatomy, the 11th edition. They also show you on 156 the stress projection, the clenched PA wrists, and then they show you radial deviation. But the two that I feel like we see more often that we did not get a chance to get to in that last recording are the carpal canal or carpal tunnel and the carpal bridge. So the carpal tunnel or carpal canal is the Gaynor-Hart method, and this is on page 158 in your book. This carpal canal used to be something I feel like that was quite common back with typing, and secretaries a lot of time had this, but now I feel like they try to make things ergonomically friendly, whether it's the keyboard or the mouse, or there's so many things to help with this. So this may not be as big of a thing as it was, but the Gaynor-Hart method or the carpal canal is a tangential, meaning skimming, infrasuperior projection. Okay, and if you look on 158, they reference that the patient would be seated at the end of the table with their wrist and their hand on the image receptor and palm down. You would ask the patient to hyperextend or dorsiflex their wrist as far as possible by either using a piece of tape or some kind of band, and hyperextend that wrist, ideally until the long axis of the metacarpals and the fingers are at a 90-degree angle to the image receptor. So ideally you would like these to be perpendicular. So metacarpals and fingers perpendicular to the IR. The central ray is angled 25 to 30 degrees proximally to the long axis of the hand, and it's directed to about 1 inch distal to the base of the third metacarpal. Okay, so central ray angulation 25 to 30 degrees, and it should ideally come in 1 inch below the base of the third metacarpal. So I would say probably right about here. I'm not sure why they have it all the way out here, but in theory, you would probably have it right about there. Okay, and then if you do that correctly, the image should look something similar to this. You can see this one they've just labeled, this one is not labeled, but the carpal sulcus is demonstrated in this. You can see the pisiform and the hamate are separated. The scaphoid is actually in profile, and this is actually a nice image. This one to me looks a little bit better because they're taking this away, which kind of is distracting to the eye. So this is what that image would look like, and they're looking right in here. A lot of times, if patients had surgery to correct that, they would go in and surgically, I don't remember if it was a ligament or a tendon that they would sever, and that could help a lot with carpal tunnel issues. Now I'm sure it's not that extreme. I'm sure there's a bunch of different ways that they can help the patient alleviate that kind of pain. The second image that we were discussing, or on that last recording that got cut off, is the carpal bridge, and this is actually on page 160. So the carpal bridge is also a tangential projection, meaning that the central ray is skimming apart. Okay, so on this particular image, they tell you that the patient is standing or seated at the end of the table, and they're placing their dorsal surface of their hand, which is the back of the hand, onto the IR. So dorsal surface on the IR so that the palm is up. You center the dorsum of the hand to the center of the IR, and the central ray is angled 45 degrees distally to go with the long axis of the forearm. Okay, and the central ray is directed about 1.5 inches proximal to the wrist joint. So if the wrist joint is here, it's about 1.5 inches up and it enters right here. Okay, if that is done correctly, then the image would look something like this. It's a tangential view of the dorsal aspect of the wrist. The center of the light field is at approximately the 3rd metacarpal. And then you can see they outline here that this is the trapezium and the trapezoid, the scaphoid here, lunate, triquetrum, and then they're just showing you this would be 1st digit, this would be 5th digit, and these are the metacarpals right here. And then you can see the capitate, which is the largest of the carpal bones right here. Okay, so these are specialty views of the wrist, and sometimes the registry does like to question on those. All right, so I want to make sure we hit on those so we didn't forget it. Now moving into the forearm. This is also in chapter 4, and it begins on page 161 are the positions, but the anatomy of the forearm, we'd have to go back to the beginning of the chapter. And if we look at the anatomy of the forearm, with this particular image, the forearm and the radius on this would be on page 128, figure 4.13. Okay, you can see they identify the radius, which is always on the thumb side. The ulna, those 2 bones are long bones that make up the forearm. And then you have joints at either ends. One at the proximal end, you have the elbow. At the distal end, you have the wrist. Okay, so this is on page 128, figure 4.13. This next image here is also on 128, figure 4.14. I would tell you that this is the radius. This is the ulna, so we know that with it like this is in an AP position because the bones are not crossed over one another. So this would be thumb side, this would be 5th digit side. On this, there's all kinds of anatomy with the radius and the ulna. On the radius, we have the radial head, the radial neck, and the radial tuberosity. Then you have the body or the shaft of the radius. The radius has a styloid process near the wrist, and then it has 2 radial-ulnar joints that are where the radius and the ulna join. You have a distal radial-ulnar joint, which is close to the wrist. There's also a proximal radial-ulnar joint, which is closer to the elbow. Those joints allow the forearm to rotate. And then we have the ulna right here. Again, it has a styloid process near the wrist. The ulnar head is actually very distal, unlike the radius where the radial head is proximal. The ulnar notch is helps make up the distal radial ulnar joint. Then you have the body or the shaft. And then we have the coronoid process with an N, coronoid process here. You have the olecranon process, and then you have the coronoid tubercle that sits medial. And then in between this, you have the semilunar or trochlear notch. That's in this next picture, actually. The proximal ulna is 4.15 is where this picture is on page 128. And we said we have the radial notch. This makes up the proximal radial ulnar joint, the coronoid process right here, the olecranon process here, and then you have the trochlear or semilunar notch. Semilunar meaning half moon or part moon. Semilunar or trochlear notch, because as you know, everything in our field has at least 2, typically 3 names. Moving on, as far as the rotation of the forearm, this is on page 132. Okay, and the rotational movements, they tell you that generally the forearm is absolutely not radiographed in a PA projection. okay? A lot of times students will mistakenly place the hand palm down, and they will try to do a PA forearm, but that is not correct, because when you make the hand PA, or when you pronate it, what happens is that the radius crosses over the ulna, and that is not going to give the radiologist any information on what's going on with either of those two bones. Okay, so and this allowing this to cross over is because of the proximal and distal radial ulnar joints. So when we do a forearm, we do an AP forearm with the hand supinated, palm up, elbow is straight as well, and that will allow visualization of the radius and the ulna independent of one another. Okay, so this is figure 4.25 on 132, and this is correct, this is incorrect as far as positioning goes. All right, so knowing each nook and cranny and crevice on each of these bones is absolutely vital to your success as a radiologic technologist. We say it all the time in our field. A lot of times it just looks like we push a button and take a picture and that's it, but there is a lot of knowledge behind that button pushing. We know everything that goes on in the tube, how that image is actually created with the radiation interacting with the image receptor. We know the electricity flow that takes place. Not only that, do we know the imaging characteristics, we know how we achieve the brightness and the contrast on our image, and we should know our anatomy so that we know if we are positioned correctly or incorrectly, and if so, how to make those adjustments. So if you're not feeling strong in this anatomy, go back a few slides and make sure that you can take the independent bone out of the box of bones in the room, take the skeleton, find some way to make sure that you get this anatomy to stick so that it can benefit you out on clinical rotation as well as long-term in your career. Positioning of the forearm. Routine positions include an AP and a lateral forearm. That is the case with any long bones. You typically will do two views at 90-degree angles to one another, and you have to include both joints on your initial imaging. Now, what do I mean by that? I mean the initial images, you have to include the joints at both ends of the long bone. Okay, so ideally the proximal joint and the distal joint. Now, that's on initial imaging. When you're doing follow-up imaging, like let's say you fall skateboarding and you go to the hospital, you've hurt your forearm, and they're going to image your forearm. They have to do both an AP and a lateral, and they have to capture both the elbow joint and the wrist joint on those images. But when you follow up with an orthopedic doctor and they're doing follow-up imaging, it is possible that they only get the joint closest to the site of injury. Okay, we'll talk about that a few more times because that's the case with any long bone. Technique on a forearm is 70 kVp at 2 mass. So hand and wrist, we were 65 at 1.2. Now we're getting a little bit thicker, a little bit meatier in the forearm, so we go up slightly in technique. This is an AP forearm. In an AP forearm, this positioning is actually on page 161. Okay, an AP forearm would show any fractures or dislocations of the radius or ulna, any pathologic process like osteomyelitis or arthritis. Typically, you're at a 40-inch tabletop SID, and ideally you are on a 14 by 17 IR with the long axis of the image receptor goes with the long axis of the part. So if you were doing this on a 14 by 17, you would want the forearm to run with the 17-inch aspect of the image receptor, but you will collimate from side to side. Okay. Patient is seated at the end of the table with their arm and hand fully extended and palm up. Ideally, when they're seated at the end of the table, they're not facing the table. They're either facing to the right or the left, depending on which forearm is injured. The shoulder needs to be dropped on a forearm so that the entire limb is on the same horizontal plane. What do I mean? I mean shoulder, elbow, and wrist all have to be within the same plane. So you could have the patient drop their shoulder, the patient could slouch in their chair to achieve that, or you could actually raise the table height so that when the arm is raised, that it puts it in the same plane with the shoulder. Whatever works best for your patient, whether they slouch in the chair, whether you build up the image receptor, or you raise the table. If you raise the table, recognize you're going to have to raise your SID to maintain 40-inch tabletop. You want the center of the forearm in the center of the image receptor. You basically, remember, have to include the wrist and the elbow joint. And then you want the patient to place their entire wrist, forearm, and elbow in as near a true frontal position as possible. What you'll find a lot of times is if the patient can have their hand supinated and their wrist is AP, sometimes their elbow will not be quite AP, but you try to get your best as far as getting that as straight, depending on where the injury is. If the injury were closer to the wrist, I would attempt to get the wrist straighter. If the injury were closer to the elbow, I would focus more on trying to get the elbow straight if you couldn't get both frontally straight on. Your central ray, this is probably the first time we haven't had a specific area, but a lot of the extremities, the central ray is mid-part. So it's mid-forearm, midway between the elbow and the wrist, in the middle of the forearm. Okay, so we'll collimate the lateral borders. Typically, you want to be your collimation to go just beyond the area of interest, and you have to make sure that you get at least 1.5 inches of the wrist and elbow joint on this image. So the marker would go lateral to the part as it's hung. So I would argue that this marker should be on the other side, because when this hangs, it hangs fingers up. Okay, so far everything we've talked about, fingers, hand, thumb, wrist, and now forearm, all of these images hang fingers up when you're looking at them. If this is done correctly, this is what it would look like. So hand would be up here, so it hangs fingers up. This is elbow joint, this is wrist joint, and I would say we definitely have about 1.5 inches beyond. Okay, you have to include from carpals to the distal portion of the humerus, because you need both joints to image long bones. The humeral epicondyles are in profile. And as far as technique, this looks pretty good. You can see soft tissue outline, you can see bone trabeculi. All of those are important when you are imaging a patient, as far as knowing if you've got an acceptable amount of brightness and contrast. Okay, so this shows an AP of the entire radius and ulna with the minimum of the proximal row of carpal bones. This has not only the proximal row, but it also has the distal row. And you have to have pertinent soft tissue shown as well. And the long axis of the part goes with the long axis of the image receptor. The next image that we take is a lateral forearm, and this is on page 162. So again, you want to keep the patient's shoulder elbow and wrist in the same plane. You're still at a 40-inch tabletop SID. You're still collimated from side to side. And now you would bend the patient's elbow. And at the same time, I would say that we would turn the image receptor. So you bend the patient's elbow and turn the IR to go with them. And you want the elbow in a 90-degree angle. Okay, so shoulder, wrist, and elbow still in the same plane. You want their hand and wrist also in a true lateral position. If you bend the elbow 90 and then place the hand palm down, you pronate the hand, you're going to cross these two bones over one another, which is unacceptable. So you need elbow at a 90, wrist lateral, metacarpals superimposed, and ideally I would probably straighten the fingers out so that the hand look more like a karate chop, but this is acceptable as long as the hand and the wrist are in a lateral position. The central ray again is perpendicular to mid forearm, so midway between the elbow and the wrist. And if this is done correctly, you will have again the carpals and the distal humerus because you'll include both joints. You will see the elbow flexed in a beautiful 90-degree angle, just like that. The head of the ulna should be superimposed over the radius, which is right down here. These are superimposed, which looks good. And again, exposure factors look terrific. Okay. Elbow is definitely got to be at a 90-degree angle. If the patient was not able to achieve that, then you would likely have to do a cross-table lateral. So if the patient is ambulatory and can cooperate, those are the only two views that you would do, an AP and a lateral forearm. If the patient was a trauma patient and unable to, then ideally what you're trying to do, what you're trying to achieve, you can tell that this patient is laying on the table. Maybe she was in a motor vehicle accident or a water skiing accident, something where she came in and she was not able to sit up. You could have the patient scoot over on the table and still place the image receptor on the table. The three things you want to make sure you're watching for is that the part is parallel to the image receptor, the central ray is perpendicular to both the part and the IR, and your central ray is mid-forearm, so midway between wrist, which is right here, and this crease in the elbow, that's your antecubital fossa, right here. So you're midway between here and here, so there's central ray. 70 at 2 is your exposure factor. You want, on extremity, you want small focal spot. So ideally you want the shortest possible exposure time so that your patient does not move, especially in a trauma situation. Oftentimes this might not be their biggest injury. They could be going into shock. They could just be in excruciating pain. And a lot of times that causes more motion than we would like. And then for your lateral, you would likely leave the patient just like this. Unfortunately, there is no slide for this, but if you did this as your AP, you could leave the patient's arm like that, slide the IR out and stand it up, and take your tube and give yourself a horizontal beam. And then you would be doing what is called a cross-table lateral. Okay, so the tube position for a cross-table lateral and a decubitus are exactly the same. The only difference is when it's a decubitus, it means that you're looking for air fluid levels. When it's a cross-table lateral, that means you're not looking for air fluid. You're trying to achieve a lateral image of the part without placing the part in a lateral position. So if I take the tube and I have the tube come this way and I'm shooting cross table going like this with the central ray, when it projects, it's still going to give me a lateral view of this part, but I've achieved that with manipulating the tube not the patient. Okay, so again, forearm is two views at 90-degree angles to each other, an AP and a lateral, 70 kVp at 2. You're going to use a 14 by 17 collimated from side to side only, and the marker is placed lateral to the part. So if it's a left forearm, it will be placed on the left side of the forearm so that when it hangs, it's on the left. And if it's a right forearm, it would go to the right of the part. Now, truly, is there anything wrong if it's somewhere else? No. It's just for consistency with the radiologist. That's where they prefer it. But as long as it is anatomically correct, it does not matter. All right, so we've touched on a few things today. Hopefully that makes sense. Please feel free to write down any questions or comments, concerns you might have. We can address those during class. And I hope you have a wonderful rest of your day. Thank you so much.